This will be available on YouTube. So my name is Catherine Briette. I'm a hospitalist, and this presentation is a joint effort with Dr. Kavik of Hospital Medicine, Dr. Sears, and Dr. Wanwatana. There we go. All right, first is a conflicts of interest statement. We have none. No one with financial stake in any of the trials presented here today. For CME, this is forthcoming, so I think next week will be on the cloud, but for now, if you've attended this meeting and you would like CME, please email me and I will collect a list and get it to the CME department. If you would like to watch the session later, it's available on YouTube, and this is the link. We'll send that out via email. And your speakers today, since we're just screen sharing, you need a visual. Dr. Wanwatana is one of our pharmacists here in charge of infectious disease care, and Dr. Ted Sears is a critical care medicine specialist. They're two of the most affable people in the institution, so feel free to ask questions. Just to get started, the view from above here, as of the 8th of this month, yesterday, we've had 537 positive cases in Maine, 58 of those here at Maine Med, and as of yesterday, 33 were hospitalized. Over here on the left, you can see how many patients have received the 3 treatments that Dr. Wanwatana is going to talk about today. And some encouraging news, which is we in Maine are very fortunate to not be experiencing anything like this on the left. This is the most up-to-date data we have here on the right as regards to our census. Very low slope linear curve. So we can all be thankful that Maine is indeed the way life should be. The objectives today are to discuss the pharmacotherapeutics. We'll start with some case reviews. Minky is going to review clinical trials underway here at Maine Medical Center, and Dr. Sears is going to get a little more in the weeds with the therapies we're all more familiar with. What we learned last week is that there is an illness script for COVID, but not every patient follows it. The CT chest does help diagnose COVID, but it should never replace clinical judgment. And pretest probability matters. People who have a high pretest probability in a negative test, we all should be aware that this does not rule out COVID, and that the source of the sample matters a great deal. So on to our first case for this week. This is a 44-year-old gentleman who is presently healthy, has a history of kidney stones. He lives on a farm with lots of animals, and on the 21st of March acquired a laptop from an IT worker who later reported to be COVID positive. This patient developed symptoms a day later and then went to the emergency department a week later. He had 2 swabs on that first day, 8 hours apart, and they were both negative from the nasopharynx. He had LFT abnormalities and a mild AKI that resolved, but no other significant lab findings, and he had very mild interstitial infiltrates, predominantly on the right on his chest x-ray. He started Levaquin, and per the infectious disease consultants, a repeat test was done 48 hours later. This was also negative. Given his oxygen requirement and relatively young age, he had a rather aggressive workup for other atypical causes of pneumonia. He also underwent a CTA for a PE, which showed atypical alveolar infiltrates. His airborne precautions were DC'd and his antibiotics were broadened. The 1st of April, his oxygen requirement increased somewhat rapidly. He underwent bronchoscopy of his right and middle and lower lobes and had extensive zoonotic testing from those samples. His last fever was that day, and then his oxygen requirements escalated to high flow nasal cannula overnight. He was restarted on airborne precautions the next day, and they called the lab and asked for COVID samples to be done on his bronch specimens. These indeed returned positive. So he started hydroxychloroquine per our protocol, which Minky will review. He was diuresed, his antibiotics were stopped. He eventually titrated down his nasal cannula and did very well. So the lessons we learned from this case, a healthy person with about an average length of illness, as far as we can tell, He had a length of stay here in the hospital of 12 days, and his care may have been delayed by his delay in diagnosis. His hydroxychloroquine was started day 5. So just remember that even if it lives on a farm and it quacks like a duck, it's probably still a duck. And if the nasopharyngeal swab is negative, you may need to ask yourself, where is the virus? In this case, it was in his lungs. So there's that old medical adage of rob the bank, because that's where the money is. Our next case is an elderly woman who is a known COVID positive from the community. She has atrial fibrillation and sarcoidosis chronically on hydroxychloroquine. So you'll note from the date here, this was a very early case for Maine. She was one of the first people to be hospitalized. Her husband was also COVID positive and hospitalized. So she presented with fatigue and malaise, minimal respiratory symptoms. She was febrile, but she was not hypoxic. And because of her frailty and advanced age, with an abundance of caution, she was admitted to the hospital for observation. On admission, her hydroxychloroquine was held and she received supportive care. The following day, she was still on room air. She did well with PT and OT, and she was discharged home, and we restarted her hydroxychloroquine. She did very well. So the lessons from this one that remain unanswered are, should hydroxychloroquine be continued in those who are on it chronically? And Minky will discuss that further. And also that the severity varies. This woman was in the hospital for 24 hours and her husband was here for 12 days. And then the discharge criteria, just to review for us, are either a stable oxygen requirement or improving oxygen requirement, or none. So CMS has now approved COVID-19 as a diagnosis for home oxygen. And as long as the patient can perform their ADLs or someone can help them, we will send them home. She followed up with the respiratory care center and did fine. And our last case for today, this is a 70-year-old gentleman who has hypertension and hyperlipidemia. He is on an angiotensin receptor blocker, but otherwise healthy, very active, retired person. His symptoms began on the 9th. A week later, he was COVID positive, and his PCP called him 4 days later, and he didn't sound so good, so the PCP arranged EMS transport to the emergency department, where the patient was found to be hypoxic on a non-rebreather, and he was intubated in the emergency department. His chest x-ray is here on the right, and his labs are down here below. You can see he has many of the typical findings. Initially, he received empiric antibiotics, hydroxychloroquine, and lung protective vent settings. And infectious disease helped us with a compassionate use application for Remdesivir. He was treated per standard protocol for septic shock. He required proning and paralysis for his ARDS. He grew MSSA and was treated with cefazolin. He did receive 1 dose of tocilizumab, and then following that was treated with Remdesivir via the compassionate use program. He had a tracheostomy placed on the 6th due to his prolonged intubation. On the 7th, he was weaning and then acutely decompensated. He had new AFib with RVR, worsening hypotension. His antibiotics were broadened. He was diuresed, and he was ultimately diagnosed with a pulmonary embolism by CTA and started on a heparin drip. Yesterday, his platelets took a deep dive and his PF4 antibody returned positive. He was started on bivalirudin. His pressor requirement escalated. Nitric oxide was attempted. Thrombolytics were attempted. Repeat paralyzation was attempted. And unfortunately, this gentleman passed last night after changing his code status to DNR with his wife over the phone. So just to review his radiology, his chest x-rays go from left to right here. And then his CTA, which was obtained on the 7th, is down below. And you can see his pulmonary embolism in the right there. And the lessons from this case, which we'll discuss further next week, but one is that thrombophilia is starting to be recognized as a COVID phenomenon. And they think this has something to do with the D-dimer elevations that we see in these patients, but we will discuss that further next week. And then this patient really did push our knowledge regarding pharmacotherapeutics about COVID. And then the rest of his care was really kind of bread and butter ARDS care. So once again, if you would like to send your name to me via email for CME, I will make sure you get that. And without further ado, we'll move on to Dr. Wongwatana.
Hey, thank you everybody for attending today, and thank you for the invitation to talk today. So again, my name is Miki Wongwatana. One of 3 infectious disease pharmacists here at Maine Medical Center, also the co-director of the antimicrobial stewardship program. So today, I want to be cognizant of time and make sure we leave enough time for both Q&A at the end and Dr. Sears to give his talk too. So a lot of this will be a very abbreviated. I do plan on providing a much more comprehensive, longer webinar talk around in about a week or so if folks are interested in attending that. But bear in mind, today will be a very 10,000-foot view approach. So in terms of pharmacotherapy, which is kind of my quote-unquote expertise in infectious diseases versus SARS-CoV-2, there is none. And if I can rephrase that, there is none with proven efficacy and safety. So that's something to bear in mind as we go forward, and I'll talk a little bit about the clinical trials that we've fortunately been able to latch on to. So suddenly, you're starting to see in the news as well as the publications in both preprint, non-peer-reviewed, and some of these higher reputable journals like JAMA or New England Journal of Medicine about drugs that are coming out of the woodworks, especially drugs like chloroquine, hydroxychloroquine, HIV medications like lopinavir, ritonavir, remdesivir, which I will go through, and then some non-infectious disease specific drugs like sarilumab and tocilizumab, which are monoclonal antibodies. So here's a screenshot of always an ongoing algorithm that's going to be updated on our intranet portal. So bear in mind, this could look a lot different in about 5 or 7 days as either A, new data comes out, or B, we enroll in more clinical trials. So as of right now, this is the most recent iteration. What you'll see at the very top is that what our guidance document wants folks to think about is to evaluate every patient for clinical trial eligibility first. I'll go over some of the off-label utilizations of medications in a little bit, but we don't want to bypass the clinical trial thought process. The second one is the evaluation of compassionate use or expanded access medications. So as of right now, the drug remdesivir also exists to give to patients under an extended access trial only. There is still a compassionate use for pregnant women and pediatric patients, so that's something that's still available for those folks as well. So zooming in on the evaluation for clinical trials, we are, as of today, at Maine Medical Center live, going with our remdesivir moderate and severe criteria. I won't go through the too in-depth details, but I've left some NCT numbers if folks want to look at those trials online as well. So we are screening patients for enrollment in both remdesivir trials. I will get to the inclusion-exclusion criteria in a little bit, but I want to go through the bottom half of the algorithm. So the bottom half, after consideration for trials is complete, you see on the far left side some outpatient guidance. And for both asymptomatic and symptomatic patients, from a drug standpoint, there is no data, or the data extremely limited to provide any type of medications, whether it's hydroxychloroquine, whether it's ivermectin, which is now coming out, or azithromycin, to either treat, lessen the severity, or prevent the transmission of SARS-CoV in the ambulatory setting. So from our standpoint, when looking at the totality of the data, we strongly caution against the use of outpatient medications that's brand new, especially the combination of hydroxychloroquine and azithromycin. Moving to the right, you see some inpatient breakdowns. So, when patients come in on floor with O2 requirement, that is where a lot of the data that exists, whether it's weak or not, talks about the use of hydroxychloroquine and some of these other medications. So the use of FDA-approved drugs off-label may be considered. Are we pushing it? Absolutely not. But we wanted to provide some guidance if folks wanted to use it. Here's how to use it safely, but also consider the risk and benefit profile. So in brief, I wanted to go over the remdesivir since I think that's what a lot of folks are curious about. So this is a very complicated structure of how a SARS-CoV virus enters the cell and then wreaks its havoc. But the area of which we're interested in is for remdesivir is where the RNA is being replicated. So the way remdesivir works is it's an adenosine analog, so it incorporates itself during the viral RNA transcription. So it looks and acts like an adenosine, but it does not allow the chain of the RNA to continue to grow, and it acts as a chain terminator. So it is categorized as an antiviral, which is accurate. When we look at the history of remdesivir, we see it fail in Ebola trials in terms of an overall survival standpoint. So these two drugs that I've listed under here are now going forward in Ebola trials, and remdesivir has since stopped their Ebola trials. So to date, there is no FDA-approved indication for remdesivir, and that is why it's the only way to get it is through those clinical trials and or compassionate expanded access. And the efficacy in COVID-19 is still very largely unknown, although we're hearing a lot of reports, anecdotals, news reports, maybe even one-to-one conversations with colleagues across the country that it is helping these patients, but we still don't have that data to review thoroughly and fully. From a safety profile standpoint, when patients do receive remdesivir, as we are enrolling patients more and more, what should we be looking for from an adverse event standpoint? In those old trials, you don't see a lot of detail, but what we do know is that AST and ALT can increase. Now, you see the wide range in which the onset can occur, so 5 to 25 days of onset. So that's something to be mindful of too, is that there is no tight range in terms of LFT abnormalities. You can see phlebitis during the infusion period, so that's something for nursing staff to be aware of. And then patients have reported constipation, dyspepsia, headache, and nausea. There was a single death in the Ebola trial, which they did not go into much detail about, but they did conclude that they could not fully distinguish that this was a drug-related mortality as opposed to a fulminant Ebola mortality. As I mentioned earlier, there are 3 clinical trials ongoing for remdesivir expanded access, which we are currently not at MMC enrolled in. But we are enrolled in the moderate and we are enrolled in the severe. So those are 2 trials that locally we are part of. Some commonalities in the inclusion and exclusion criteria that exist in both studies. So this is going to be the key in that for inclusion, patients need to have their PCR test within the last 4 days. So if you look back in their medical record and they had a outside facility that's day 6, day 7 of the PCR testing, automatically these patients will not be eligible for both trials. There is the age of greater than 18, or you have some pediatric application for patients between 12 and 18 years of age as well, with parent or legal guardian consent. And the radiographic evidence of pulmonary infiltrates. Common exclusion criteria, and this is going to be key going forward, where we saw a slide deck earlier where about half patients were receiving hydroxychloroquine. It is an exclusion criteria if patients are on this drug and have not had 24 hours without being off of the drug. So this will hopefully, as we go forward, we're going to do some education, some slowing down of the starting of hydroxychloroquine so that we can ensure that these patients, if they are eligible for trials, we do not exclude them or give them a reason to be excluded. Patients who have baseline LFT abnormalities upwards of the 5 times upper normal limit, as well as AKI, creatinine clearance less than 50 mils per minute, are also excluded. And then breastfeeding women, positive pregnancy, and known hypersensitivity. So how do you deal with a pregnant patient? I would advise once we get down the compassionate or expanded use, that's something that we can still try to get for pregnant patients as well. What are some major differences between the moderate and severe? Something that separates them apart. So for the moderate trial, these are patients who are meant to be on room air and not on any supplemental oxygenation. So any patients who come in, positive test within the last 3 days on room air, they're qualified to enter the moderate trial. For severe, they are allowed to be on mechanical ventilation, but it cannot be more than 5 days, or receiving any type of ECMO. So this is something to keep in mind. While we might think clinically severe as someone who's been mechanically ventilated for 10 days, or even patients on ECMO, for the trial purposes, the definition of severe may not meet the clinical definition of severe. So that's something to bear in mind as well. So there will be time to ask questions about the trial later. I do want to go into the whole, blowing up of chloroquine and hydroxychloroquine. So this all first started in late February when this report came out, summarizing an audio press conference about how chloroquine was working in their patients in China. And so that led a lot of folks to do some in vitro testing. And this is a very crude and summarized version of seeing how chloroquine may have some benefits in both preventing the virus from entering, preventing the virus from replicating, and preventing post-entry as well. So there is supposed a three-pronged mechanism for chloroquine, hydroxychloroquine. Another study came out in Clinical Infectious Diseases trying to look at the dosages. So what you see at the very bottom is what the PEDAL trial will now be utilizing, which is a 400 milligram loading dose followed by 200 milligrams twice a day for 5 days. Now, clinically, this is something we need to be very cognizant about. There is not a lot of rigor in the clinical reported data that we can review. So the top study there by Chen and colleagues, you see that the outcomes that were measured were very crude. So body temperature normalization, they summarized improved pneumonia, but they don't really go into detail what they mean by that. But they did show a percentage difference in their 31 versus 31 randomized trial that about 81% of hydroxychloroquine recipients had improved pneumonia as opposed to 55% of the control. They did have numerically higher, sorry, I think that should be switched. 2 patients receiving hydroxychloroquine versus 4 in the control. And they summarized by saying hydroxychloroquine may confer benefits in earlier time to temperature control, improved pneumonia, and progression to illness. Now, the second study actually showed no benefits, much smaller cohort, 15 versus 15, but they saw no difference in PCR negativity by a week, no difference in body temp normalization, and maybe slightly higher LFT abnormalities in the hydroxychloroquine as well. So this was actually a no benefit trial. And the last 2 studies, which has been kind of glorified in the media, there were 2 French studies in which the first study was a viral presence and absence outcome. So there was no clinical outcomes discussed at all. And this is where the origination of azithromycin combination came about. So when you hear about in the media about adding azithromycin, bear in mind, ground yourselves and understand this came from a viral clearance and no clinical outcomes paper. However, the authors were confident enough to conclude that they recommended the combination to be used in every single patient. So that stirs up a lot of debate in the medical society. The same authors looked at a bigger cohort, 80 patients, which they published this paper about 4 or 5 days later. Again, this was a no control comparator, and they actually included the same 6 patients as their previous paper. They went on to double down on their recommendation, and still they discussed a little bit about clinical outcomes, but they still went on to tout their PCR negativity as the main reason why they should do it. So this is my personal take, and I know this may differ amongst other clinicians, but there is data that exists, so I don't want folks to think there's nothing out there. The in vitro hypothesis does make sense, and we do have some clinical data to review, but the rigor is severely lacking. There's been a lot of debate as to the biasness of some of these designs. It does provide hope in an area where we have unprecedented pandemic scenario, but I always caution folks who are prescribing these medications, both in and outpatient, to use rigorous risk-benefit profile assessment for each of these patients. Uniquely assess your patient and understand, and think, is my patient going to benefit even a little bit at all, or am I putting more harm by adding this drug? This is a drug with even 5-day course is not without side effects. Now, long-term side effects such as retinopathy, we probably aren't too concerned about it. These are seen in patients who are on this drug for years and years and years. But the short-term side effects to be aware of, which we all know about cardiac abnormalities, QT prolongation. But it can cause hypoglycemia, it can cause GI disturbances, and some patients will have CNS side effects such as extrapyramidal reactions as well. So there is a potential for MainMed to join an ORCID study, which is a PEDAL study, and that's something that's exciting. I attended a training session yesterday going over inclusion-exclusion criteria, and hopefully these patients will be able to capture those who may not qualify for the Remdesivir study. The next drug I'm going to talk about in brief is tocilizumab, and why was this something that came about was the concern that there's a cytokine storm associated with patients with COVID-19. So this is not an infectious disease drug. This is an anti-immune modulatory drug. But Something to keep in mind, there's actually good aspects of IL-6 and bad aspects of IL-6. And in the good aspects of IL-6, we may be actually doing harm if we do IL-6 blockade. But in the bottom half of that pictorial, where if we believe that the IL-6, the immune cytokine response is doing harm, we can see a potential reduced mortality and reduced lung inflammation if we provide a therapeutic that decreases this IL-6 storm. The current FDA-approved usage of tocilizumab, there's only 2 right now. One is in the rheumatologic population, and one in the CAR T therapy where patients may have cytokine release syndrome. Things to be mindful of in patients who receive it. So infections like secondary bacterial infections. If patients are currently battling a bacterial infection on top of the viral, we highly, highly suggest avoiding tocilizumab at all costs. Tuberculosis, this is something we know of with a lot of monoclonal antibody therapies. So for any patient who is even being considered for tocilizumab, we definitely 100% recommend checking a quantiferon gold prior to initiation. And if the lab comes back positive downstream, we do suggest treating for latent tuberculosis. Some side effects to be mindful of in previous trials that we've seen. So there have been case reports in those 2 subpopulations like RA of serious liver failure. And in terms of patients who show up with LFT abnormalities, there is some recommendations to even start this drug, so be careful of those patients as well. We might see some neutropenia in some of these patients, so there is no true known mechanism as to why this is, but some folks have hypothesized it's more of a margination as opposed to suppression. There's been one report that we can review thus far of tocilizumab, and that's in the Chinese population, where they give a single dose to patients who already received standard of care for 7 days. You see the mean IL-6 of these patients were quite elevated. Lymphopenia, which we see in a lot of our patients, was in 85% of the 21 patients, and CRP was elevated in all of them. So this, to me, is more of a Hail Mary approach in patients that do not respond to maximized standard of care ARDS management, but we still need to be cognizant of the side effects. There's some stringent monitoring and strict criteria for use locally here as well. Of note, I've sent a feeler out to a company who's starting a tocilizumab study. We've been put on kind of the back burner as a site in case one of their sites either cannot enroll enough patients, or if they need more patients to enroll. So we are kind of in line for that tocilizumab study as well. So from my standpoint, from a pharmacotherapeutic summary for COVID, from an outpatient standpoint, my preference is there is no risk-benefit profile that we can weigh and say, okay, we're starting these new medications in an unmonitored setting. There's been no data that suggests that these patients will benefit by any means. So please avoid, in my opinion, outpatient prescribing of these medications. For clinical trials, there actually are trials that exist. So if patients, healthcare workers, or even exposed contacts are interested, as of this past Monday, the University of Minnesota, in collaboration with some Canadian institutions, have started a pre-exposure prophylaxis with hydroxychloroquine. So they're looking for as many people interested in enrollment as possible. So I'll be happy to forward those as well. For an inpatient standpoint, trials. So as we start going live with more and more trials, we're going to try to push the consideration of enrollment of these patients in the trials as much as possible. Now, before today, of course, we would consider off-label utilization because we didn't have any trials to consider. But as we have more trials, this should be first and foremost what we consider for patients. Then, if patients are unable to enroll, look at the data and please read it and digest it for yourself. But hydroxychloroquine for inpatients may be reasonable with close monitoring. From a COVID standpoint, we do suggest avoiding azithromycin, but we do understand that azithromycin can still be used for bacterial pneumonia. So that remains unchanged in our pathways. And then last line therapies such as tocilizumab should be avoided and made as a joint decision with pulmonary critical care, infectious diseases, as well as the patient as a shared decision. So again, that was a very rapid crash course, making sure that there's some time for Dr. Sears as well. So,
can I ask a couple of follow-up questions just pertinent to that before we go to Dr. Sears? So Minky, can you speak to the Remdesivir trial, the inclusion criteria of a PCR positive test within 4 days? So if a patient has been tested outpatient and they're presenting at day 7 or 8, as they are more apt to do, that person would be ineligible, or we would retest that person to confirm that they still have COVID evident disease by testing? What's the recommendation there?
Yeah, so I'd have to take that. My initial response would be, because their initial test was positive at day 7, day 8 prior to, they would be ineligible. Even if we check it again and it's positive, I don't believe it would reset the clock and allow them to be eligible for enrollment.
Okay.
So it's from the initial test. So if they got it at on March 31st and they were asymptomatic, hung around at home for 8+ days, 8-9 days, even if we tested again and it's still positive, they would not be eligible for enrollment.
Okay. And then a question from the chat just about how patients are going to be screened for these trials overnight. Is this a 24-hour-a-day workflow?
This is a 24/7 workflow in terms of screening. In Amion, if you look down below in the pharmacy section, there is a COVID pharmacist that's assigned to do screening 24/7. From an 8 a.m. to 8 p.m. standpoint, there's always an infectious disease pharmacist on site to do the screening. And then overnight, we've assigned 4 team members to also do that screening as well.
Thank you.
Yep. There's a number, is 662-0232, if you have questions on screening in real time.
All right, thank you all. So Ted Sears is remoting in, so he's going to unmute himself, and I'll be advancing his slides from Bram Hall.
Okay, well, thanks very much for asking me to chat today. I'm going to be talking about some less exciting, more basic topics, but nonetheless, I think there's a lot of, there's a lot of lack of clarity about what our strategy should be in terms of steroids, fluids, antibiotics, things like that. And I will do my best to give you my thoughts. As Minky has mentioned, one of the joys of this right now is there's almost no data, so you can sort of run with your biases any direction you want. I did want to just mention this, and I'm not sure if people have seen this before. This is a model out of Italy talking about etiologies of COVID hypoxia, and they are at least theorizing that there's 2 phenotypes. This sort of phenotype L, and you can see down the bottom, those are people who have more mild infiltrates. They don't have a huge amount of lung involvement. They tend to have lower inflammatory markers, higher compliance, and less consolidation. And then we have this sort of phenotype H, where you've got a lot more consolidation, a lot more inflammation, and they're actually much more ARDS-like. And their feeling is that patients can be quite severely hypoxic in the phenotype L, but what we don't want to do is have people progress through from phenotype L into phenotype H and develop full-on ARDS. Next slide. So this may have treatment implications. Once again, this is, there's not any huge database here. I think people are coming up with these things sort of on the fly. But one of the ideas is we'd really like to prevent people from, moving from phenotype L to phenotype H. And a lot of the things that we think about in terms of good, care, and while people have ARDS, may also be helpful in sort of trying to prevent this transition and trying to prevent people from developing full-on ARDS. And that includes, good supportive care, but sort of more specifically this talk, steroids, they have a role. They're certainly anti-inflammatory. Does minimizing fluids have a role? Maybe there's, as you guys have probably heard, there's a lot of talk about early proning. Should we be proning people, on nasal cannula? So anyway, I'm going to focus on fluids and steroids, and then talk a little bit about the approach to antibiotics. Next slide. So as you all no doubt know, steroids have been studied ad nauseum for a lot of different things. We have a fair amount of data about the effects of steroids in viral infections. And, for example, in flu, there have been multiple trials of using adjunctive steroids in influenza, and most of those have shown prolonged hospital stays and even increased mortality in patients who have flu. The MERS-CoV, the Middle Eastern Respiratory Syndrome coronavirus, steroid use in that virus was associated with increased mortality and with increased viral shedding. In general, most data has not shown a lot of benefits to steroids in viral infections, similar, to COVID-19 or ones that progress to ARDS. ARDS itself steroids have been studied a million different ways. Many of the studies are negative and no benefit. Some of the studies have shown a little bit of benefit. The meta-analysis, that is most recently quoted, which UpToDate has a good summary on, did show possibly some early benefit, but I'll tell you, it's all over the map. The benefit is not huge, certainly, and I will tell you, most critical care doctors are somewhat skeptical about steroids, although some people do like steroids in ARDS. Finally, in sort of sepsis and septic shock, which also plays into this, we have studied them extensively. There's not a huge benefit for mortality. The only real benefit is duration of septic shock, and therefore, we tend to not use steroids except when we really want to use them as a way to get people out of septic shock. They don't seem to have a huge benefit towards mortality. So what do we know about steroids in coronavirus? This was published in JAMA a few weeks ago. This is, you'll notice from the curve over there on the right, they are claiming that your survival probability is a much better if you got methylprednisolone in this study. What I will tell you is that I would regard this with extreme skepticism. This is retrospective, uncontrolled data from a single center of 201 patients. There's probably a huge amount of selection bias. Most of these patients are on other adjunctive therapies. It's pretty hard to isolate the effect of the steroids. This paper, if you look at it, was basically just statistical test after statistical test after statistical test of everything that they tried for these patients to see which ones looked significant, and what do you know, methylprednisolone showed up as significant. And reading some of the other literature that comes out of China, they tend to be sort of steroid happy, and they use a lot of steroids over there. I will say I just don't find this incredibly convincing. Next slide. The CDC, has generally taken the position that corticosteroids should be avoided, basically on the position that there's no good data, and that we know that in MERS-CoV and influenza, they don't help. Next slide. The Surviving Sepsis campaign has decided to go the opposite direction. You'll notice at the top there, mechanically ventilated adults with coronavirus without ARDS, they suggest against systemic steroids. I think implying that they tend to agree that viral infections don't generally benefit from steroids, but that they are more of a believer in the benefit of steroids in ARDS, and therefore have a weak recommendation towards using steroids in ARDS. Although I underlined the bottom there, which was apparently a fair number of people on the committee did not really want to send out a recommendation at all. Once again, this the sort of steroid benefit potentially seen in ARDS was really a meta-analysis of a ton of different studies with a ton of different methodologies. It was not done in the era of low tidal volume, high PEEP. I'm admittedly a steroid skeptic, but I'm a skeptic about ARDS and steroids. Next. So I will personally say I'm not going to go there really. Next, you can hit it again, Catherine. I am not prescribing steroids to patients with COVID-19. I don't think the data supports it, and I'm not convinced that there's a huge amount of benefit. Although I am not, if people feel strongly about it, there is a real lack of data, and there's no thing to say that it's not going to help, and maybe we will discover it does help. One thing I will just point out though is I really do give steroids when people have other lung disease, right? If they've got bad asthma, or they've got bad COPD, if they've got a steroid responsive ILD, I think we should have a very low threshold to be getting those patients on steroids, and I would not withhold steroids with the concern of coronavirus. So if they're COVID positive and they've got asthma, they should get steroids. For some of these other ones, UIP pattern IPF, if we really think they're having a flare, we can certainly use steroids. Sarcoid, we can use steroids. CF, we might want to use steroids. But I think for the people who you would normally give steroids to, by all means give steroids to, but I just wouldn't give steroids to the pure coronavirus patient. Moving on to fluids. You guys, I will say once again, no data. So most of what I'm going to talk about here is just by analogy from ARDS. You guys may have, or may not have heard of the FACT trial, but this is one of the foundational trials for ARDS management. And the FACT trial really showed that less fluids is better in ARDS. And so you will notice that they trialed a conservative strategy versus a liberal strategy here. There was a significantly larger number of ventilator-free days in patients who got the conservative strategy, who got less fluid. And so you get people off the ventilator a lot quicker. And there were, other benefits in terms of various other organ systems. So we generally like to keep people, like to try to minimize fluids. Now, we obviously have a lot more of invasive ways to measure fluid balance, and we can use CVP in the ICU, but we tend to early diurese people with the FACT, per the FACT trial protocol, to really try and keep them really even at 7 days. If you have to use fluids up front, you're going to diurese them off pretty much as quickly as you can. Next slide. So the sort of principles of the FACT protocol are: we don't use maintenance fluids on patients with ARDS in the ICU. We bolus them when we think they're dry, and we try not to keep them on 125 an hour or 200 an hour. We do use, our other medications and nutritions. We manage electrolytes and blood products per usual practice. You bolus people for fluids. You can, in the FACT trial, you were allowed to use fluids or blood or albumin. And and we diurese people as soon as they're hemodynamically stable. In the ICU, if your CVP is greater than 8, you get diuresis, and if it's greater than 4 and you have decent urine output, we diurese you. Next, maintenance. So next slide. So I guess this is sort of what I would take away from this, which is that, if your patient is dry, they certainly need volume, and I think we should be avoiding acute renal failure and hypotension. But that once we have hemodynamic stability, we should be trying to run people dry. We know that large volumes of fluids are going to worsen the inflammatory process in the lung that leads to ARDS. And so we should really be driving people back towards neutrality. If we have to use volume up front for them, which we may, we should be trying to drive them back out. I would say that if your patient is otherwise stable and looks like they can tolerate diuresis, I think there's, a dry lung is a happy lung, as pulmonologists often say, and we would, tend to favor, gentle diuresis for people who we think are hemodynamically stable and can otherwise manage it. But, you don't need to put people into renal failure. Last, antibiotics. Huge problem. Obviously, it's very hard to tell when your patient comes in with infiltrates whether this is COVID or a bacterial infection, and even once the COVID is positive, you're concerned about co-infection or superinfection. There's really a lack of rapid diagnostics. I'll mention, we'll look at a little bit of procalcitonin data in just a minute. It would be nice if procalcitonin was going to work here, and I'm not convinced it's going to. And then what I would say is the set of virus sepsis guidelines is suggesting empiric antimicrobials over no antimicrobials. Once again, weak based on no data. And the CDC says do it if you think it's likely. Next slide. Just a quick word on procalcitonin, which we don't have here at Maine Medical Center, but would has been shown to be a reasonable marker for bacterial infection in the respiratory tract. This is the data that came out of one of the New England Journal articles, and you'll notice that a very significant percentage, 13% of patients with severe disease, and these are mostly patients who have severe disease in terms of CAP. So this was the ATS IDSA, community-acquired pneumonia severity. So those would basically be admitted patients. And then patients who were in the ICU or ventilated or died, 25% of them, a quarter of them had elevated procalcitonins. Once again, this is totally uncontrolled data. A lot of these patients are on steroids. A lot of them are also Tamivir. The Chinese also reported very high rates of late multi-drug resistant antibiotic pneumonias in their COVID patients, and we worry about antibiotic overuse. But there's also this concern about procalcitonin and the cytokine storm. Maybe the reason that procalcitonin is up is because they're having the cytokine storm that Nikki already mentioned. Once again, uncontrolled data, just looking, there's an odds ratio, an elevated procalcitonin is highly associated with severe disease with coronavirus, but is that severe disease because of cytokine storm? Is that severe disease because you're actually co-infected with other bugs? I don't think that procalcitonin in the short term is going to answer our questions, unfortunately. Next slide. So I think we're going to just do our best to make the best clinical decisions we can. I think empiric antibiotics are probably appropriate in many patients. We try and get culture data, and then we try and de-escalate. And we keep we continue to be surveilling aggressively for signs of superinfection, obtaining new cultures when people clinically change, and do the best we can, understanding that we're not going to have an easy answer. And those are my thoughts on fluids, steroids, and antibiotics.
Great. Thank you so much, Ted. Questions from the audience?
We have one question from Katie Davenport about the decision-making around steroids on admission for patients with COPD. One of the challenges we're having is that we are hooded in PAPRs, and so ability to hear wheezing and so forth is really pretty limited at this point. We are using point-of-care ultrasound, but how do you approach that, Ted? What is your advice there?
I mean, what I would say is that we know that, I would be short of shocked in a patient with known COPD if there wasn't some element of COPD exacerbation going on with a COVID infection. And so once again, I think that patient, if they really look great and you give them a hit of albuterol and they've got no response, maybe you hold off. But I would tend to go ahead and give that patient steroids, thinking that there's a pretty good likelihood that they're going to be developing some element of COPD exacerbation along the way here. But once again, you all you can do is what you can do, and it's very frustrating not being able to listen to their lungs.
Ted, a couple of follow-up questions. One, you've outed yourself on not having shaved your beard for your N95, and Dave's calling you on that. A question for you and Minky about azithromycin. So there's, whispers about the benefits of azithromycin. It obviously complicates the QTC issues with hydroxychloroquine. What would be the advice on use of azithro? Should we be switching to doxy? How do you think about that?
I will say certainly that I don't know of. I know that there's been a lot of talk about the combination of azithromycin and hydroxychloroquine. There's just no data, and I don't regard azithromycin as inherently a better drug than doxy. So my personal feeling is if you're putting someone on a drug that might prolong their QT, you might as well ideally choose a drug that doesn't prolong their QT. Although if you have to use another QT prolonging drug, just check their QTC.
Yeah, this is Minky, and talking to both internal and external providers, here in the institution, when you can monitor things from a bacterial standpoint, I don't really push back in DCing azithromycin if it's for the bacterial component. People approach me and they want to add azithro to hydroxy for anti-COVID purposes. I will push back on that. But the alternative to doxycycline is appropriate as well if the reason for using azithro was the atypical activity.
Any other questions? You can use the chat with Dan, or you can unmic yourself and speak. And then Patty Stogsdale, if you're still in the audience, if you have anything you want to add to all of this, we'd love to hear from you.
I think the question about how do we get better at identifying bacterial superinfections is really important. And I'm disappointed to hear Ted's perspective on procalcitonin. I was hoping to have optimism there. I know Patty has not been supportive of that. There's a question from Lisa about should we be doing more urinary antigen testing in this environment for Legionella and other things?
Yeah. I will say I've always liked the urine antigens, both for Legionella and also the strep pneumoniae, antigens. And so I personally think they're totally fine. I think that if they're positive, they're clearly going to push you towards antibiotics. Just the problem is that there's a million other things we can't test for, and so the negatives are never all that helpful, and you're still back to your clinical judgment. But I'm a fan of urine antigen testing in general. I don't know about that. I can't claim that other people, you know, Patty Stogsdill may have different feelings.
All right. Any other questions? Okay. Well, thank you very
Hi,
much.
this is Katie Lou. I have a question. We've seen really inconsistent ordering of ferritin, troponin, D-dimer, and CRP on admission, and I don't know if that should be something we should be doing in a standardized way to help identify patients who are at higher risk or any kind of risk stratification for going to the ICU. If anyone on has any opinions, that'd be grateful.
I believe on the COVID order set, there are labs that are pre-populated, and for the trials in particular, we are looking at those parameters. So when you are in the order set and you're thinking this might be someone who is going to go to trial, either Orchid or Remdesivir, it would be great to get those labs on admission.
I do think that from the ICU perspective, you know, it's very hard to interpret elevated inflammatory markers, and mostly what we're going to be doing is you know, looking at the patient and looking at their hemodynamics and their respiratory status, and you know, if they have an elevated CRP and an elevated, you know, D-dimer and an elevated ferritin, but they look pretty good, we're not going to do much different. So once again, I think that honestly, I feel like those are probably still more in the research phase than they are in the clinical relevance phase at this point. But I would be happy to be proven wrong and be given good predictive tools about how people are going to do with COVID.
Patty, are you there? Are you able? I know Patty's trying to chime in. Okay. No.
Yeah, I can't unmute her. That one's me. Patty, if you call my cell phone, I'll put you on speaker.
While we're working on that, Lisa Almeida is asking about MRSA swabs and whether we should be getting those. My point of view is typically those are pretty helpful on patients we're hospitalizing with pneumonia, and I think we ought to be doing those regularly for our pneumonia patients. And I don't know if there's any reason to be doing that for COVID in particular, but ought to probably be part of our standard process. Any thoughts on MRSA swabs?
I agree with you, Dan.
I think they are helpful to do that, because especially some of these patients that are coming from, you know, assisted living facilities or some of the nursing homes, if we can get that, I think it makes it easier to be able to discontinue some of the other antibiotics.
Are people able to hear Patty?
I'm sorry?
I'm just checking to see that people are able to hear you.
Yeah.
I'm saying yes. There's a question from Don Med about testing, and so we came back to one of the examples you gave. We had to go to bronchoscopy to actually get a confirmed COVID test. I'm wondering about use of tracheal aspirates in the ICU. Are you guys doing that? And I think, Don, the answer to your question is yeah, sometimes the nasopharyngeal swab is going to be negative and you need to go looking elsewhere for evidence of the virus. But Ted, what are your thoughts on that?
We are definitely doing them in the ICU. We have been in conjunction with ID sending tracheal aspirates pretty regularly. Obviously, we have easy access in intubated patients to tracheal aspirates, but I do think there's going to be a role for them.
So I can speak to that a little bit too. So I've been dealing with that over the past couple days, and the problem is mucus is very tenacious, and it apparently interferes with the RNA test for the virus. So we're trying out a new way of sending it down in sending the sputum to the lab, and they're going to be doing something called dip in swirl. Supposedly, it's going to be a better way to be able to test for COVID-19. But stay tuned.
Great, that's great. Wonderful. Well, we are at time. I want to thank everybody again for tuning in this socially distant manner. We will do this again next week at the same time. I'll get the invite out to you very soon. Our topics next week are going to be practicalities for respiratory therapy and thrombophilia associated with COVID. If you have any suggestions for topics, inpatient or outpatient, please email me. My email is here on the screen right now. I'd love to hear from you, and any feedback you have on this format, we're kind of learning as we go, is much appreciated. Take care, everybody.
Thank you.
Thanks, Ted. Thanks, Mickey.
Thanks.